Hello, everyone. Welcome to today's wonderful webinar, Evaluation of Antibody Response After COVID-19 Infection and Vaccination, presented by Wondfo Biotech. So first of all, our dear audience and our distinguished guests, thank you all for joining today's event. My name is Leah Lee, and I'll be hosting today's webinar. I'm from the Wondfo International Marketing team. And today we have two keynote speeches from Dr. Gheyath and Dr. Hadi. And after these two parts, we will have a short Q&A section to answer questions from our dear audience. So now, Dr. Hadi and Dr. Gheyath, could you say hi to all the audience?
Hello, everyone.
Hello, Dr. Gheyath.
Hello,
yes, we can hear you.
Hi, everyone.
Good morning, everyone.
Hello, Dr. Hadi. Nice to see you.
Thanks for hosting us today.
Okay, thank you for joining. And so for the schedule today, we will have the webinar expected to 1.5 hour duration. And the first part will be Dr. Gheyath to introduce his keynote speech of evaluation of antibody response to SARS-CoV-2. And the next part, it will be Dr. Hadi to share his speech on enhanced disease illness due to COVID infection and vaccinations. And at the last part, we'll have a short Q&A section to answer the questions from our audience in the chat box. So don't forget to leave your comments and questions in the chat box during this whole event. Also, a recorded video will be uploaded to Wondfo YouTube account, so you can check the playback and other reviews. And next, I'm going to introduce our two guests today. Dr. Hardy Yasmin, he is an associate professor of infectious disease at Qatar University. And he's serving as the head of the research at Qatar University Biomedical Research Center, which is QUBRC. And he has published more than 120 articles, cited more than 5,500 times based on Google Scholar, and some of which are in the top tier scientific journals, such as Nature, Nature Medicine, Cell, Lancet Infectious Disease. Dr. Hadi has an excellent experience in virology, microbiology, immunology, and vaccine development. He worked at the Vaccine Research Center under American NIH for over 5 years as a postdoctoral fellow. And today, Dr. Hadi will sharing his knowledge on antibody-dependent enhancement, as known as ADE effect in COVID-19. Another speaker is Dr. Gheyath Nasrallah, and he is associate professor at Qatar University, experts in infectious disease. He has published more than 110 original research and reviewed articles in international journals such as New England Journal of Medicine, Nature Medicine, and Nature Vaccines. And if you have paid attention to the vaccine effectiveness in COVID-19 variants, surely you have noticed that recently an outstanding study about Pfizer vaccine protection against the variants has been published on New England Journal of Medicine. And Dr. Gheyath is one of the contributors to this great work. And today, Dr. Gheyath will give us the introduction about his research on antibody response after COVID-19 vaccination and infection, as well as sharing his original validation on wonderful FunCare anti-SRBD antibody assays. So really looking forward to hear about the two excellent speech from two excellent experts. So next, let's welcome Dr. Gheyath to present his speech, Evaluation of Antibody Response to SARS-CoV-2 Natural Infections and mRNA Vaccines using a different type of immunoassays. Dr. Gheyath, please.
Thank you. Thank you very much. Hello, everyone. Thank you, Leah, for this introduction. And I would like to thank Wondfo and all of the attendees as well that are going to attend my presentation. I would like to thank the College of Health Sciences that I belong to. And also I would like to tell you that I am affiliated to the Biomedical Research Center. And most of the fund I get it from Qatar University and from Qatar National Research Fund. And today I'm going to talk about the evaluation of antibody response to SARS-CoV natural infection and vaccination using different type of immunoassays. First, I will talk about different assays, mainly chemiluminescence assays, and then we will talk about the Wondfo validation of the Wondfo new assay. So before I start my my presentation, I would like to give you a general background about the genomic structure of the SARS-CoV, and I also would like to give some introduction about the proteins are encoded by this virus, as these proteins are very important for our talk later on. So SARS-CoV is one of the biggest RNA viruses, and it contains about 10, the genome contains 10 open reading frames. 6 of them are overlapping. And the most open reading frames that are important to our talk is open reading frame 1, which contains 3 sub open reading frame 1A, open reading frame 1B, and open reading frame SEM and N. So as you can see here, that the N encodes for the nucleocapsid protein, and the M is encodes for the M protein, and the E is encodes for the envelope protein, and S are encoded for the spike protein. So most of the diagnostic immunoassays use the N protein and S protein as target for detection. The most important protein are also used now for vaccination and evaluation of antibody for vaccine is the as the spike protein, which consists 2 most important domains, the S1 and the S2. And the S1 is the trimeric protein, and it has to be cleaved from S2 so the virus can enter into the cells and cause infection. And you know here there is a cleavage site, and there is one paper we try to publish, we publish it actually in Journal of Clinical Investigation, that we think children are less susceptible to infection, as these children sometimes are they have high titer of antibodies against seasonal coronavirus, and these antibodies can bind to the fusion domains here, so where the S1 and S2 cannot cleave and the virus cannot enter the cell. I mean, this is one hypothesis why maybe children less susceptible, but now children are infected as an adult, and there could be other reasons why maybe children are less susceptible. So also within the S1, there is a very important within the S1 subunit, there is one important domain or subdomain we call it receptor binding domain, where the receptor binding domains are important. Binding domains are important to bind to the ACE2, which is the angiotensin converting hormone, that is the receptor for the viruses. So if somebody have an antibody to the S1 or form or form antibody to the receptor binding domain, the virus cannot enter. And there is people talking about there are some within the receptor binding domain, there are some amino acids that are important for binding of the virus to the infected cell. So during my talk, I'm going to talk about questions, answer questions, and there are 8 questions, the most, and I summarize them here. So the first question that we need to answer, are there significant discrepancies in the seroprevalence between automated immunoassay in population with high incidence of SARS-CoV-2? Are automated assay substantially underestimate SARS-CoV infection in high exposure setting? And I will explain this later on. And can ELISA automated assay or lateral fluorescent immunoassay, like the one from Wondfo, be utilized to predict neutralizing antibodies after SARS-CoV infection and vaccination? And what about vaccination? Do Moderna and Pfizer vaccine provide similar antibody response? Does natural infection produce better antibody response than messenger RNA vaccine? Does antibody response decline after vaccination or infection? And how much is going to be, very high and enough for protection? And the last thing, can we use fluorescent lateral flow assay to predict neutralizing antibody? And at the end, I will talk about validation of specifically to the Wondfo assay, lateral fluorescent assay for predicting neutralizing antibodies. So the answers for our these 8 questions, most of them we answered them in this recently published paper that I'm going to talk about the main points of this paper. And also, here we submitted also recently to Journal of Travel Medicine a paper where we comparison the antibody immune response between 2 different messenger RNA vaccine, which is Moderna and Pfizer. Now, at the beginning of pandemics, the most automated immunoassay that were used in Qatar are the CL900, which were being used in the primary healthcare centers, VIDAS from Biomedics, Liaison, Ellipsis, and up. So just to give you a brief introduction, the CL900 from Mindray is detecting the IgG against the spike protein and the nucleocapsid protein, the whole spike protein, S1 and S2, and it depends in chemiluminescent technology. However, VIDAS is detecting specifically the receptor binding domain of the S1, or I can call it S1 RBD, and detect the IgA, and the technology is the electrofluorescent assay. The Liaison diacerine from Italy is detecting antibody against the recombinant S1 and S2 protein, IgG. However, now Liaison, they feel that their sensitivity of the assay is not very high, so they develop new tests now where they use the solid phase that are coated with the trimeric S protein. Ellipsis and Abbott, Ellipsis Roche and Abbott have the same technology before, but they have now new version. For seroprevalence, they were using the solid phase is coated with a nucleocapsid protein where it detects total antibody IgG, IgM, and IgA, and IgA of the nucleocapsid protein. However, now for vaccine evaluation, Abbott and Roche, they developed new methods that are where the solid phase is coated with the spike protein. Now, before I'm going to show you the result, I just want to show you the source of our sample, where we get our sample from. And also, it is very important now to show you the differences in the seroprevalence in two type of community, two type of people, or according to their occupation, age, and where they live. So the first seroprevalence study, it is done in collaboration with the primary healthcare centers. So if you don't have an idea about Qatar population is about 2.6 million, and we have primary healthcare centers that are distributed all over the country, more than 25 primary healthcare centers. And there is about 1.3 million registrar, and registrar, of course, not all of them are adult, they are between adult and children. So in July 2022, or July to August, we sent messages to 19,000 individuals to participate in our seroprevalence study. And actually, there is more than 2,000 people responded to our call, with good response rate is about 11%. And we measure the prevalence of SARS-CoV RNA and also seroprevalence, and the overall prevalence in the primary healthcare centers. I mean, this is in normal population. There is no overcrowding, and in the major part of the community. The overall prevalence was about 15%. PCR prevalence is 1.6, and the anti-S and anti-IgG at that time was about 13%. And as you can see in this table, the prevalence is significantly higher in male, and also associated with higher age group, and also because most of the population of the Qatar are coming from different area. So we found that the high prevalence are found in people from Southeast Asia, and also the prevalence associated with the geographical distribution, and depends on how much crowding in that area. So this is the phase 1 of the study. Phase 2, we call the same 2,000 people to participate in our study again, and to measure their antibody level after 3 months, and to measure the seroprevalence. And as you can see, about 1,000 people responded, and the seroprevalence of IgG and IgM was about 17% after 3 months. So there is about 3% increase in the prevalence. The other study is very, very interesting study. We performed this study in collaboration with the Will Cornell University and Ministry of Public Health, and we targeted people that living in very crowded area, and mainly these people, they visit the Red Crescent centers for getting medication and for getting health care, and those people are mainly males and craft manual worker, and they live in the industrial area. So we collected sample nasal swab and also serum from about 2,600 people, and we measured the PCR prevalence and the seroprevalence, Most of our population, as you can see, they are less than 40 years old. The total prevalence was about 60%. And if you compare it to the primary healthcare center, the prevalence, although they conducted in the same time, that one from July to August, and this one from July to September, the prevalence was 60% in this study. In that study, if you remember, in phase 1, it was only 14%. PCR positivity is 11.3 in this study. In that study is about 1.3, and we measure the antibody again using the Roche, ELIXIS Roche, and remember, ELIXIS detect antibody, total antibody to nucleocapsid. However, in the Mindray assay, it detects S1, detect S and nucleocapsid. And we found also that prevalence is significantly associated with geographical location, also level of education, type of occupation, and nationality. And as you can see here, the most vulnerable people to infection at that time were people from Bangladesh and Nepal. The most interesting finding in this study that these young people, 98% of the infected people are they don't require hospitalization, and most of them are asymptomatic. Now we use the samples from the Red Crescent study to answer the question. To answer this question, does the performance of the assay affect the seroprevalence and determination of the ever infection? I will talk about first the seroprevalence and what is the ever infection. So the question, if we use different assay than Roche in the Red Crescent study, would that affect the seroprevalence? And the answer, as you can see, it's summarized here. So to do so, from the 2,600 sample, we ask the computer to randomly select samples, and we collect about 400 samples from the 2,600 Red Crescent sample. And the PCR prevalence in these 400 sample was about 12.5, and the ever infection, meanings here, the ever infection that are the past and the current infection. The past and some, as you can see, as you know, some people are PCR positive, and at early time of infection, they do not develop antibodies. Or sometimes the PCR is negative because they were positive by PCR, and after 14 or more than 14 days, they become negative. So the term ever infection means anyone who were positive by PCR or positive by any of the assays, of these three assays, VDAS or Mindray or ELIXIS, we consider it positive. This is the ever infection. Now, if we measure the seroprevalence by any of these three assays, is that going to affect the results of the seroprevalence? As you can see here, but if we use VDAS, Mindray, or ELIXIS, the seroprevalence in these 400 samples are almost the same, although these three assays detect different antigen. If you remember, VDAS detect the SRBD, Mindray detect S and N, and ELIXIS Roche detect the Antigen. And the seroprevalence in this three assays was almost the same. And the three assays show a high level of correlation between almost 90%, which is very high. Now the question, how going back to the same question, if the ever infection. So the samples that are positive by any of the three assays or PCR is about 216 samples, which is about 55%. And Mindray was able to detect only 78% of the ever infection cases, Elixis 77, and Vidas even less, is about 74%. In conclusion, any of the assays, any of this three assays was able to detect only 80% of the positive cases, and more than 20% of the positive cases were missed by any of the assay. So the take-home messages that I want to convey here in high exposure area, maybe you need to include more than one assay to detect, to accurately determine the seroprevalence. As you can see from this table that were published in the same paper in the scientific report, these are the sample where they have discordance between the results. As you can see here, some people, they have very low CT value, high positive, but they are still negative by the Mindray or the Biomerics, and only positive by Roche. This can be explained by those people, they are at early time of infection, and yet they don't develop antibody that are the antibodies that can be detected by the assay. Similar thing here. You can see that sample could be positive by Roche and Mindray, but are negative by Vidas, and some sample are negative by PCR, but are positive by the serology assay. And even here with samples that have high CT value, okay, you can see that not all of the assays that are able to detect the antibodies. All right. So this figure just to show you the CT value of the most of the positive cases. And now this is, we consider any of PCR positive sample, regardless the CT value, we consider them as positive. And you know now the situation is different. Now we consider only people with CT value less than 30 as positive are positive for SARS-CoV, and they have to repeat the test after a few days. This is just to show you the concordance between the assays, although they detect, as I said, they detect different type of antigen. And as you can see, the high concordance that achieved was between Vidas and Biomerics. It's almost about 0.91%, followed by Mindray and Elixis, and the worst concordance was between Mindray and Biomerics. Now, in the previous study, we were comparing PCR to the serology data, and maybe someone will tell, no, maybe if we want to validate the assay, or if we want to measure the sensitivity and the specificity of the assay, maybe we need to use a reference serological assay, to validate any of the new assay. And also, as you know, the most important thing in SARS-CoV infection is if you are developing a neutralizing antibody against the infection. So the next question that we want to answer can ELISA automated assay or lateral flow assay be used to predict neutralizing antibody after SARS-CoV infection or vaccination? First, I will talk about the prediction of neutralizing antibody in infected people, and then at the end I will talk about the vaccination people in vaccinated. We published this paper to evaluate 3 assays, and we also published another paper that I will show it to you for evaluation of some assays for prediction of neutralizing antibodies. The reference assay that can be used for determining of neutralizing antibody is the conventional method, which depends on live virus, and it will in this assay you will measure the amount of neutralizing antibodies that can bind to the receptor binding domain and block the virus from binding to its host, to the host cells. And in our example, it's a tissue culture so the antibody that can block the virus from binding to the cells and prevent cytopathic effect formation. However, this assay is needs biosafety level 3 because of highly infectious nature of the SARS-CoV. You need also to perform tissue culture, and you need to do also a lot of titration to have the titer, and this will increase the cost of the assay. There is another assay now people use instead of live SARS-CoV virus. They use the pseudoviral assay where they express the S protein in HIV and using a reporter gene. However, in 2020, GeneScript they developed an assay where you don't need a biosafety level 3. And also you don't need a tissue culture. It's totally depends. I mean, you can the principle is totally depends or similar to the ELISA assay, or it is ELISA assay. And the results of the assay were validated in this paper, where they validate the assay in different labs around the world, and the result, if you want to look at them, they are published in Nature Biotechnology, and they found that this assay is the correlation between this assay and the conventional assay or the pseudoviral assay is almost more than 80% or more 0.8%. So this is the surrogate neutralizing assay or virus neutralizing assay by GeneScript. The assay is called now CPAS. It's an ELISA assay where the solid phase is coated with the ACE2 receptor, and the liquid phase is the S protein where it's conjugated with enzyme. So if you have a neutralizing antibody, they will bind to the RBD and prevent the RBD from binding to the ACE2. And after washing, all of the conjugate enzyme will be removed. So the higher, the lowest signal you have, the highest titer of the antibody. It is a competitive ELISA assay. Now, GeneScript recently got the full FDA approved. And from our experience, we use this assay a lot, and then we think that this is the best assay that are available in the market to be used as a surrogate for the viral neutralizing assay. Now, so we want to validate our automated assay, the sensitivity, specificity, and also the predictive value for prediction of different assays. So in our assay, we for our study we use about 115 samples. we collected samples from symptomatic and asymptomatic individual. And you know that the antibody response in symptomatic is stronger, and we have some people that we could not classify them. We also include them in our study. For specificity, we use pre-pandemic samples from 127 samples. We select our sample carefully, where we used samples from people that they have they are an ANA positive. They have some people they have other coronavirus positive, seasonal coronavirus, and also other corona like MERS and SARS-1. We have few samples, and also from non-respiratory viruses like RSV and influenza virus. And here we measure the sensitivity and the specificity in comparison with the viral neutralizing assay, with the surrogate viral neutralizing assay. As you can see, the sensitivity of the all automated assay, Liaison, CL900 and BDAS is above 90%. However, the sensitivity increased significantly when we use symptomatic patient, and we know now that now because we know that the amount of antibody that are produced by symptomatic patient is higher than a symptomatic patient. And you can see that although there is some differences in the sensitivity, but all of them have a good acceptable sensitivity. This figure, I want to show you that as you can see here, the amount of antibody that are produced in symptomatic by any of our assay is significantly higher than the asymptomatic people. Something that I want to mention in this slide, that what about the Igm response? A lot of people ignoring Igm, although some papers indicating that high neutralizing antibodies in infected people, Igm participate a lot in the in neutralizing of the virus. And you can see that this is the first study we did it during pandemic. We used ELISA, and the amount of Igm produced is very high in symptomatic and asymptomatic. This is Lyonix very sensitive ELISA assay, and you can see that like about 75% of our infected people with SARS-CoV, they produce Igm. This is not the same. We recently find this is not the same scenario in the naive vaccinated people, where they don't produce that much amount of. Most of them are negative for Igm. This is a big difference between the infected and the naturally infected and the vaccinated people. So similar to the first study, we did another study in collaboration as well with Abbott and Roche, and this time we use 100 and the same samples, and we measure the sensitivity and the specificity of the assays. I just wanna here we use different assay. Again, we use Mindray. We use Abbott, which detect the anti-N protein, the IgG, and we also use the Ortho new diagnostic technology, which is recognized by FDA as well. We use the Petrus, which detect total antibody against the S1 subunit. The S1, if you remember, it is include the RBD domain. And we measure the sensitivity in comparison with the surrogate viral neutralizing assay with the CPAS. As you can see, the highest sensitivity was for Petrus, and this makes sense because Petrus targeted the S1, which contained the RBD, followed by Mindray, which detect the S and N, and the least sensitivity was for Abbott, because as you can see, the old version of the Abbott test is detecting the nucleocapsid, the IgG against the nucleocapsid protein. So we have done some correlation study as well, as you can see here, in comparison with the SDN, with the surrogate viral neutralizing assay. I just want to, this is one of our mistakes, that in this type of correlation, we use Spearman. In this, we found that Pearson correlation maybe is better to test than the Spearman. And this is the most important test that someone will do to see the correlation between two assays. As you can see here, VIDAS has high correlation with the neutralizing antibodies with the ASFIN. This makes sense because VIDAS and the surrogate viral neutralizing assay targeting the RBD. However, VIDAS only detect IgG. However, in CPAS, you detect all antibodies, IgM, IgG, and IgA, and all subclasses of IgG to the RBD domain. Also, MINDRAY showed good correlation. Liaison also Abbott, although detect N, but also the correlation is about 0.6. Anything above 0.5, we consider it very good. And as you can see, both VIDAS, because they're detecting S1, they have high correlation with the viral neutralizing assay. Now the other, now we switch gear from infected people to vaccinated people, and also about the validity of the assays using vaccinated samples. We have done similar studies, but also we have also studied more. We focus now in immune response rather than validation of the immune assay. So 2 months ago or 3 months ago, we published a paper in, as you can see, in Nature, where we showed that the mRNA 1273, which is the Moderna vaccine, has better effectiveness for protection than the Pfizer vaccine. So we asked ourselves this question: is this why Moderna provide better protection? Is this because Moderna produce higher titer of antibody, higher titer of neutralizing antibody than the Moderna, or producing more antibody to the IgG? So we want to answer this question. So we characterize the immune response from people that are that they receive the Pfizer, and other people they receive the Moderna vaccine. So we collected about 300 samples. Most of them are, and the most common vaccine that are used in Qatar is the Pfizer vaccine. And so we collected about 200 samples from people vaccinated with Pfizer, and almost 50 samples from people vaccinated with Moderna. And also we characterize them into naive, that they are never been infected, and we make sure that by asking the participant or testing them for anti-nucleocapsid antibodies. So naive infected, they should be anti-M negative, okay? Because Moderna and Pfizer, they targeted antibody against S. Yani people are injected with the S trimeric protein, okay? And also we divided our participant into three age category: people less than 30 years, people with 30 and 50 to 50 year and people more than 50 years. And we want to see if the antibody response in this age group are different. Antibody response is different from one age group to another. So what we expect now, as you can see, we measure the total antibody response to the total antibody response to the RBD, the SRBD, for people with Moderna and with Pfizer in naive and previously infected people. As you can see here, Moderna, the Moderna group produced 3.5-fold more total antibody than the Pfizer vaccinated individual. And if you have a previous infection, the level of the response is higher. Even you will develop more antibodies than Pfizer and than Moderna alone if you have a previous infection. But unfortunately, as you can see, in most of our previously infected people, they are mainly receiving Pfizer vaccine. We wish, and hopefully in the future, that we will have more people with Moderna, that they receive Moderna and they are previously infected. Now, what about the SRBD IgG? This is very important. Still, as you can see, Moderna produced more antibodies. People, Moderna group produced 2-fold antibody more than the Pfizer vaccine, and previously infected people produce more SRBD IgG than the Pfizer, but not the Moderna. The neutralizing antibodies, which are the most important for evaluation, again, Pfizer produced more, the Moderna group produced more antibody. However, in previously infected people, we did not see any type, we did not see difference. And that is because, as I said, is people are more with, we have previously, they are vaccinated with Pfizer. This is surprising to us as well, the IgA response, and we can see than the Moderna produced more IgA antibody than the Pfizer, and the previously infected people, they produce also more antibody than the people with Pfizer alone. What about the age group? We did not, although we can see that the youngest age group produced more antibodies, more SRBD antibodies, and more IgA antibodies than the other two groups. However, this difference was not significant. Maybe this is because due to small sample size, if we need, because some literature say the younger group produce more antibody than the older group. We have maybe to do further study and to include more participants. Now, the other question that we need to answer as well, if we collected antibody from those vaccinated, let's call them phase 1, after 3 months, and then we ask them to come and to test their antibodies again to see if there is a decline or increase in the antibodies, in the antibody response. As you can see, unfortunately, all in the total antibody to SRBD or SRBD IgG or neutralizing antibody, or there are significant decrease in all of these type antibodies after 3 months. The interesting thing about this study that we use the same patient group, okay? That after the same patient group that we use in phase 1 and phase 2, that there is And the conclusion, our conclusion, there is threefold decrease in SRBD, IgG, and neutralizing antibody over 3 months. I want to bring also the IgG issue here, IgA issue. People at the beginning of vaccination, people think that IgA response to vaccine maybe is weak, is not as a natural infection, but this is just to prove that most of the mRNA vaccinated individual, whether this is Pfizer or Moderna, they produce high level of IgA. And I believe personally that IgA participate a lot in for protection against infection or reinfection with the SARS-CoV virus. Now we want to answer another question to compare the immune response between vaccinated and naturally infected people. Who produce more antibodies, the vaccinated or the naturally infected people? Now, we did not use the same individual, of course, but we have used the same time interval. I mean, we used samples for people that they were PCR positive after 1 month, after 2 months, 3 months, and 4 months. And also we use samples that received the first dose, 1 month from the first dose, 2nd month, 3rd month, and 4th month. As you can see in all in the SRBD IgG, at the beginning of vaccination, there are about 17-fold more increase in the vaccinated people more than the naturally infected people. I mean, the mRNA vaccine produced at the beginning high level of antibodies, of SRBD antibodies. They are way significantly more than the naturally infected people. But this difference, as you can see, declined over time. And after 4 months, from 17-fold the difference, it becomes 2.7-fold. And as you can see here, there is sharp decline in the antibody response from 4,000 arbitrary unit to about 400. So there is more than 10-fold decrease, and it is very significant. So the infected people, however, they seem to retain their antibody, although it is less antibodies, they seem to retain their antibodies better than the vaccinated people. Okay, but the level in vaccinated people is the same. Now, how about the neutralizing antibody titer? The same situation of the total antibody titer. At the beginning of vaccination, you will see high titer of antibodies, more than the naturally infected. However, this difference decreased over time, and the amount of neutralizing antibodies unfortunately declined rapidly, which is the most important for protection. And according to the assay we use, to be protected from infection, you should have a threshold of more than 100 arbitrary unit per ml. Okay, and you see most of the infected people they have less than 100. And there are many studies that infected people are more vulnerable to get infection than the vaccinated people, and this is the proof, the results of our study. You can see there is significant decline in the antibody response from 0 to 5 months. However, the naturally infected people seems to return their neutralizing antibody better than the infected people. The point that I want to to indicate here, that the antibody response in the vaccinated people are more homogenized. As you can see, the error bar is not very high here. However, in the infected people, the error bar is very high, meaning that the antibody response is not homogeneous. This is true because the symptomatic people produce way more antibodies than the asymptomatic people, and this is you can see it here as well, and also in all of our data. This is for the SRBD IgG. As you can see here, it's worse. The antibody at the beginning of the mRNA vaccinated people is way higher more than the infected people. And over 4 months, the SRBD antibody decreased from 26-fold into 2.2-fold, the difference between the infected and the naturally between the vaccinated and the naturally infected people. And the same result we saw in the total antibody and neutralizing antibody, you can see it here in the SRBD as well. Okay. The last thing that I want to talk in my presentation is the validation of fine care. So as you know, the fine care is lateral flow assay, where we have, this is the pads that is designed for testing. The conjugated pad contain the fluorescent labeled SRBD protein and the Gheyath anti-chicken antibodies, and also it has the RBD that is conjugated with fluorescent B. The test line pads is coated with the RBD protein, and the control line is coated with anti-chicken antibodies. Okay, so this is a double antigen sandwich method. So if you have a neutralizing antibody, one arm of the antibody will bind to the conjugated RBD, and the other arm of the antibody will bind to the RBD that is in the test line. So when you apply the sample, the sample is going to migrate, and if you are positive, it will bind to the RBD, and the RBD will be if you are positive, the antibody will bind to the fixed RBD here in the solid phase, and it will give you a positive result. If you don't have antibody, it's just only one line will be positive. Okay, so this is a demonstration for positive result, and this is a demonstration for negative result. So the advantage of this assay, I will talk about it in a minute, that you can quantitate the amount of receptor binding domain, or the amount of antibody against the total antibody against the SRBD. So the advantage of the technology, I'm very interested. I'm very interested in this technology, and to do also several validation, because you can use sample from whole blood or finger puncture, serum or plasma. Sample size is very small, 10 microliter. In most of the automated assay, you need a minimum 150 microliter. Turnaround time is 15 minutes, which is excellent. You can use small fluorescent reader to do the quantitation or to detect the positive and negative. Can be quantitative. Reading can be corrected from relative fluorescent unit to binding antibody unit, which is identified by the WHO. And the WHO factor is 20. So whatever data you get here by the fluorescent reader, you multiply it by 2. And the sensitivity in our hand, not by the manufacturer, and I will tell you how we assess the sensitivity, is about 92% in the infected people and 100% in the mRNA vaccinated people. We did not detect any false positive data, and it is, I consider it very cost effective for the card and the reader. I just want to tell you that this reader is less than 2 kilos. So it is very important for field study. You can carry it with you wherever you want to do the study. And can be high throughput because they have the higher version where the reader not only reading one sample at a time, it can read 12 sample together. So we assess the sensitivity and specificity using 150 samples, some of them from symptomatic, some and other from asymptomatic individual. And we assess the sensitivity according to PCR here. And we use pre-pandemic control from 100 sample, and the sensitivity was perfect. Remember, the most automated assay, the sensitivity was not more than 92 and 93%. But we have to do maybe the sensitivity in symptomatic and asymptomatic aside. But the overall sensitivity is about 90%, which is 92%, which is perfect. The specificity is 100%, and the predictive value is also very high. Now, the sensitivity of fine care using vaccinated people, we tested more than 300 samples that they are positive for neutralizing antibody. All of them, they were positive also by this assay. So to validate the assay, we did the sample distribution. First, we did it from infected people, and we want to validate the plasma results. If we take samples from plasma, we will validate it and measure the correlation with other assays. So this is the 150 sample, the average binding antibody unit that we measure by fine care from infected people is about 150. And if we compare it to the ASVENT, which in my lab I consider it as the reference assay, or the CPAS from GeneScript, the correlation is excellent to such type of assay. Okay, it's about 0.6%, which is very high. We use the Pearson correlation. And if we also do the correlation with the PDAS, as you can see, the correlation is even better, is about 0.7%. And this is expected. Fine care detect total antibody to SRBD, VIDAS detect IgG to also SRBD. So we expect high level of correlation. Now, we did it with Mindray. Mindray correlation was not excellent, and even the model was not also perfect. But however, the average, as you can see here, with the distribution, sample distribution of Mindray and fine care was very close. Now, this is from plasma infected people. We asked the question, how about if we use a finger prick? That make the advantage of the test that you don't need to draw sample, you don't need to do bleeding or vein puncture. You just need to do a quick assay from the finger. And how about the results of the whole blood from the finger? So we did correlation. We use vaccinated sample here, more than 100 to 150 vaccinated sample, and we test the antibody using plasma and using fine care puncture. And as you can see, the Pearson correlation is almost 0.9%. So the result that you get by the plasma is very similar to the result you get by fine care. Then you expect that also the fine care from finger prick is correlate very well with the SVNT. Not as good as plasma, but still very acceptable. And here I want to show you some, or even the quantitative data of the VIDAS and the finger prick. And as you can see, some of our sample by VIDAS and by the by the fine care, they are giving very similar results. Okay. However, you have some samples that they are not correlated at all. But in most samples, the correlation is very similar. As you can see, the finger prick give a very good correlation, as I told you, with the Spearman or Pearson correlation. Anything above 5.5%, we consider it 0.5, we consider it good. Now with Mindray, the model is very good. As you can see, the p-value, there is linear correlation. However, it is fair, not as strong as in the other assay. And this is with the total antibody, similar thing. This is good correlation, 0.5 with the SRBD from Mindray. Now I come to the conclusion of my study. So in this study, I showed you that symptomatic SARS-CoV patient produce stronger antibody response than the asymptomatic. Serology assay can underestimate SARS-CoV assays, can underestimate SARS-CoV seroprevalence. Moderna vaccine induced better antibody response than Pfizer. mRNA vaccinated group produced high level of IgA, and immune response to mRNA vaccine is not affected by age. SARS-CoV, SRBD, IgG, neutralizing antibody, and total antibody level decline significantly after mRNA vaccination and over time. mRNA vaccinated group produced high neutralizing titer antibody than the naturally infected individual, and fine care anti-SARS-CoV SRBD total antibody is rapid, highly sensitive, and specific assay. Fine care finger prick test results provide very good correlation with other automated assay and can be used for production of neutralizing antibody. At the end, I would like to thank my collaborator, our famous and Dr. Laytham Raddad, and also my colleague who will give a presentation just after me, Dr. Hadi Yassine. And I would also thank all my lab members who helped me in producing such amount of data. Farah, Dua, Hadil, Fatima, also Nadine and Salma. And thank you very much.
Thank you, Dr. Gheyath. Thank you so much for your amazing work on the antibody test in seroprevalence, in past infection, and in the post-mRNA vaccination group. And
you are welcome. Thank you very much.
Yeah. And we especially appreciate your work highlights the RFA, which is fine care RBD antibody test, as a rapid and convenient test, which can use finger prick blood for the test, and also have a high sensitivity and high specificity for the in the past infection and the vaccination group. Thank you so much.
You are welcome. Thank you very much.
Yeah, and also I noticed that our audience has a warm discussion about Dr. Gheyath's speech. We will select some questions and propose to Dr. Gheyath in the last part of the webinar, the Q&A section. So thank you for the audience. And the next part, we will have Dr. Hadi to sharing his speech of enhanced disease illness due to COVID infections and vaccinations. Dr. Hadi has an excellent experience in virology, immunology, and vaccine development. And today he will sharing his knowledge on ADE effect in COVID-19. And Dr. Hadi, you may share your screen now.
Thank you, Leah, for the invitation again. It's an honor to be with you. Can you see the slides?
Not yet.
Not yet, just second. Do you see it now?
Yes. Perfect.
And do you see it full screen?
Not yet. It's full screen with notes.
Okay, just let me remove other screen or just a second. Oops. I'll remove the other screen. Okay. Now you can see it.
Yes, it's okay now.
Okay. So thank you again for the invitation, and thank you, Gheyath, for the informative presentation. So Gheyath took over an hour, so I don't have much time to present this talk. I'll try to go through it a little bit fast. So I'm going to switch gear, and I'm going to talk now about enhanced disease illness due to COVID-19 infection and vaccination. I'm going to present data from already published work from other groups, not my work, because my work is still undergoing and I don't have data to present right now, but I'm going to give like a general overview about enhanced disease illness due COVID-19. Before I start, I would like to declare conflict of interest because I'm contributor to a patent regarding the prefusion of stabilization of coronavirus spike protein, which was used in the vaccine. So this is the outline of my talk. So I'm gonna first describe and explain what's antibody-dependent enhancement or enhanced viral disease illness in general. Then I'm gonna talk a little bit about antibody-dependent enhancement, which I'm gonna refer to it right now as ADE, in multiple viral infections, including some respiratory viruses like influenza and RSV. And then I'm gonna talk about evidence of ADE in coronavirus infection and vaccination using, as I mentioned, already published data. So to start by defining ADE, what's ADE? Which is also called immune enhancement or disease enhancement. It is a phenomenon by which the binding of the antibodies, or specifically suboptimal antibodies, to the virus, it leads to enhancement of virus entry to the host cell and then further replication of the virus. So instead of the antibodies binding to the virus and neutralizing it, it causes enhancement of virus entry to a host cell and then further virus replication. Further ADE may result in what we call enhanced respiratory illness or acute lung damage. And this happens after the deposition of the virus antibody complexes in the lung, and then that lead to inflammation and monocytic infiltration, especially eosinophils to that site, which lead to acute lung damage. These suboptimal antibodies that lead to this disease enhancement could be elicited from either natural infection or vaccination. In addition to these, also type 2 T helper cell dependent ADE may contribute to the development of vaccine-associated disease enhancement, which is not limited to respiratory viruses, although it's more prone in some respiratory viruses like respiratory syncytial virus per se. So when we talk about antibodies usually function in a different way, and they can eliminate or kill the virus using different strategies. The most important one is neutralization, by which the binding of the antibodies to the virus it inhibits the virus attachment to the host cell. In addition to that, the virus, the antibodies kill the bacteria or any other pathogen by what we call complement-mediated lysis. So the antibody bind to the bacteria, for example, and then the complements bind to this complex, and then the complements the complement lies the bacteria or the pathogen. Also, we have opsonization, by which the binding of the antibodies to the virus or to the bacteria enables macrophages to engulf and lyse this immune complex, including the virus or the bacteria. And the last one, also, we have antibody-dependent cell cytotoxicity, by which the binding of antibodies to antigens on cells infected with a virus enables the natural killer cells to bind to these antibodies, and then the NK cells can kill the infected cell. And also we have the T cell response that's very important in clearing viral infections. So when we talk about ADE, there are two main mechanisms of ADE, and both of them are related to the elicitation of non-neutralizing antibodies or suboptimal neutralizing concentration. The first one, we call it FCR, Fc gamma R mediated, the receptor for the Fc portion of the antibody. And this one involves the virus, the antibodies, and the cell surface Fc gamma R receptor. And the other one is complement-mediated ADE, which from the name, it involves viruses, antibodies, complement, and complement receptors. So this is the first figure that shows how the Fc gamma R play a role in ADE. As we mentioned, the non-neutralizing antibodies will bind to the virus, and then this immune complex is recognized by macrophages, and then they get engulfed inside the cell as an endosome. And then because the virus is not neutralized, it will get dissociated from the antibodies, and then that will lead to some inflammatory response, as well as further virus replication inside the cell, and then you have more virion coming out of these macrophages. In terms of complement-mediated ADE, the same thing, the virus and non-neutralizing antibodies bind to the virus, and that will initiate a cascade of complement cascades, resulting at the end by the expression and the elevation of the C3b complement, which also bind to the virus, and this 3b will bind to its receptor on the complement receptor bearing cells, and then again the virus will get internalized, and that will enhance the virus replication inside the cell rather than killing the virus. In addition to that, we also as I mentioned in the previous slide, non-neutralizing antibodies will bind to the virus, and they will deposit in the lung, and that will lead to inflammatory cytokine storm and the recruitment of different immune cells, including eosinophils, for example, and that will result in acute respiratory distress syndrome. So one of the common examples of ADE was early reported for dengue viruses. As you know, that dengue viruses, they have 5 serotypes. Infection by one serotype could provide protection against that serotype, and the protection is long-term protection. So if you're infected with serotype 1, you have protection against serotype 1, and it's long-term protection. However, if you are subsequently infected with another serotype, what will happen is that these two serotypes share common conserved epitopes, but these are non-functional epitopes. So what will happen after subsequent infection with another serotype, that will result in what we call Antigenic Syn Syndrome. So instead of targeting the new epitopes of the new virus, the B cells, for example, will recognize that, oh, we already have immunity against these conserved epitopes, and then they will start generating these non-neutralizing antibodies. So these non-neutralizing antibodies will bind to the virus, which will get engulfed by the macrophages, and then that will result in what we call Fc gamma receptor ADE, by which the virus replicate to high titer in these infected macrophages. Interestingly, this ADE does not only occur within the dengue virus serotypes. It was also reported against different viruses within the same family that are also pretty much transmitted with the same vector, the Aedes aegypti. So we know that West Nile virus, Zika virus, dengue virus, they all belong to the same viral family. These are arboviruses. And interestingly, for example, if somebody is infected with West Nile virus, the virus, the serum from this patient neutralize the West Nile virus, but it enhances the replication of Zika virus and to less extent dengue virus. The same thing if the person or the patient is infected with Zika virus, the sera from that patient to neutralize it. However, it kind of enhanced replication of Zika, of West Nile and dengue virus. And the same thing observed with dengue virus, but to less extent. So dengue virus sera neutralize dengue virus. It somehow neutralizes West Nile virus, but enhances the replication of Zika virus. So the ADE problem in the arbovirus is not within the same viral group like dengue, but also it could be a problem within different viruses of the same family, like I just explained here for the dengue virus, Zika virus, and West Nile virus. And here is a study like a table summarizing different studies from different people using dengue, either plasma or sera, or West Nile plasma, and see their effect on ADE against the Zika virus. So, and like here, different groups using different arboviruses sera, using different models, either in vitro or in vivo. Interestingly, in vitro, whatever, like most of the experiments that were done, they showed ADE, as you can see in here. However, not all of them translated to ADE in vivo. But still, there is kind of agreement between different studies that sera against dengue virus could induce ADE after Zika virus infection. Now we move on towards ADE in respiratory infections. The first of these ADE in respiratory infections were reported against respiratory syncytial virus, or RSV. And that was reported in the late 1960s. At that time, people were trying to develop RSV vaccine using the traditional method that was used before for influenza and poliovirus, which is total inactivated virus using formalin inactivation. Unfortunately, the people that were vaccinated experienced severe disease with high fever, pneumonia, wheezing. When they get infected with RSV after vaccination, the hospitalization frequency was higher among the RSV vaccinated, and unfortunately, 2 toddlers died after vaccination. And then in these experiments, they reported ADE. Specifically, they noticed that they have non-neutralizing antibodies and skewed response of the type 2 T helper with the absence of cytotoxic T lymphocytes. And we know that we need cytotoxic T lymphocyte in order to clear the virus from infected cells. And this is just a micrograph of a lung section, and this experiment was done in mice. So these mice were vaccinated with whole inactivated RSV, and then challenged And then you can see here there is infiltration and inflammation and infiltration of lymphocytes and eosinophils. And this was also associated with increased production of interleukin-4, which we know it secure the response toward type 2 response. And interestingly, if these mice were treated against type 2 response, whether by decreasing the interleukin-4 by anti-interleukin-4 antibodies or any other methods, they can see that the disease did not form and did not develop in these mice, confirming that what is really causing ADE is the skewing response toward type 2 response with the absence of cytotoxic T cell response. And there was a study published a few years ago showing that the treatment of the virus with formalin leads to conformational changes of the fusion protein, and by which then you are not really inducing good number or good titer of neutralizing antibodies. If you don't know RSV carries two surface glycoproteins, the fusion protein, which call it F protein, and the glycoprotein. Currently, most of the vaccines that are under development, they are targeting the fusion protein because we know most of the neutralizing antibodies target this protein, and it comes in two forms, pre-fusion and post-fusion. The pre-fusion has most of the neutralizing epitopes. Only one epitope is found in the post-fusion. And as simple as that, after you treat the formalin, after you treat the virus with formalin, you lose the binding of antibodies that really target the pre-fusion form. For example, here we have the D25. The D25, we know it binds to the pre-F. It does not bind to the post-F because it binds to the protein in its right conformation. And if you take pre-F but is stabilized pre-F, meaning it's not affected by treatment, it's still the D25 bind to the pre-F because it's stabilized. However, if you take the D25F and try to test the binding to RSV versus formalin inactivated RSV, you can see that the D25 bind to the RSV in its natural form, but not in the formalin inactivated form, indicating that this formalin inactivation leads to the destruction or to the conformational changes of the pre-F on the surface of the virus. And this was also confirmed by antigenicity and infectivity studies. So basically, frankly, you don't even need formalin inactivation. If you just leave the virus at 37 degrees or even at room temperature for a couple of days, the infectivity of the virus goes down because the pre-F changes conformation by itself. So the pre-F is the fusion protein is not stable, whether you treat it with formalin or whether you just expose it to 37 degrees temperature, that changes conformation and lead to the conformational change of the fusion protein, which could explain why formalin inactivation led to this ADE in RSV vaccinated individual. Another example are the influenza, and here, I'm just gonna share one story that was done in pigs, and in here they tried to immunize pigs with H1 from H1N2, and then vaccinate with H1N2, and then infect with H1N1. So you have kind of heterologous vaccination infection, and they wanted to see whether this heterologous challenge could lead to ADE. And in their study, they noticed that if you vaccinate with H1N2 and then challenge with pandemic H1N1, you have more of the antibodies that are directed to the H2, which is the stem part, but not to the head part that contain the receptor binding domain. And that was also was associated with enhanced virus replication and enhanced lung pathology in the in the pig's lung. And just as showing here, if you are not vaccinated and infected with the pandemic H1N1, you has less severe disease and less lung pathology. So vaccination with a heterologous virus led to more lung pathology at the macroscopic and microscopic levels. And as I mentioned in the previous slide, they noticed that most of the antibodies were targeted to the stem part that's more conserved, and we know that the stem part has the fusion peptide, and they claimed in that paper that the antibodies to this stem domain enhance the fusion of the viral membrane to the cell membrane, and that might lead to this enhanced lung pathology in the vaccinated pigs. Here just showing also in vitro that sera from pigs immunized with the H1N2, they have enhanced replication inside MDCK. So instead of neutralizing the virus, there's enhanced replication of the virus. And they can say they showed that if you absorb with you absorb the sera with HA2 protein, which is the stem part, you diminish this kind of replication. But if you absorb with H1, you retain it. So pretty much confirming the previous results that upon this heterologous vaccination, you are inducing more of the stem antibodies, and these stem antibodies, instead of protecting, they are enhanced disease illness. There are some problems with this study because they did not really characterize very carefully these stem antibodies, because other stem antibodies have been shown to produce protection rather than enhanced disease illness in here. But here just to showing that sometimes heterologous vaccination could be a result or could induce this enhanced disease illness, like we previously shown with dengue virus as well as Zika virus. Now I'm going to go to the subject of this talk, which is AD in coronavirus infection. I'm going to describe 4 studies. I'm going to go a little bit faster through these ones. So the first study was published in Journal of Infectious Diseases in 2007, and this was done with SARS-CoV-1, and the title was Severe Acute Respiratory Syndrome Coronavirus Infection in Vaccinated Ferrets. The vaccine used in this study was formalin inactivated vaccine like RSV vaccine. They used ferrets as animal model. For a challenge, they used homologous challenge, meaning they challenged with the same virus they used for vaccination. And the conclusion was the vaccine provided mild immunoprotection to the ferrets after a challenge. And again, this is because it was a homologous challenge. However, there were no evidence of enhanced liver or lung disease induced by inactivated virus vaccine. And here just showing that this the formalin inactivated vaccine, and this is mock, you have you still have good viral titer in the vaccinated individual. It lasted for a longer period of time. It was cleared in 7 days compared to 14 days in non-vaccinated ones. And they induced the neutralization titer, but the neutralization titer diminished with time. As they claimed, there were no major ADE or inflammation in the lung, but in their study they reported some lesions in the liver. So in this section there is the immunohistopathology in the lung, and this is one in the liver. And you can see here in the liver there are some lesions where there is a mixed population of lymphocytes and other immune cells, including macrophages. So again, in this study, they used homologous challenge. If they use heterologous challenge, it could be a different story. The other study also about SARS-CoV-1, if we can say, and the title is Antibodies Against Trimeric Spike Glycoprotein Protect Hamster Against SARS-CoV Challenge Despite Their Capacity to Mediate Fc Gamma Dependent Entry into B Cell in Vitro. So in this study that was published in journal Vaccine, they used recombinant native full-length spike trimer or spike protein, so they did not use inactivated one like the previous one. In this model, they used mice and hamster. Again, they used homologous challenge. So in vitro, they did not notice disease enhancement, but in vitro, they could see antibodies that mediate or promote virus replication in B cells. And here, like just showing the vaccine, the virus titer in vaccinated versus non-vaccinated animals, and you can see there is a significant reduction of viral titers. And here showing you have significant increase of neutralizing antibody titer, meaning that the vaccine is doing its work. But when they looked for ADE in vitro, so they used virocell and they used, for example, Raji B cell. We know that the virocell do not express the Fc gamma receptor, but Raji B cell express the Fc gamma receptor, but they do not have the receptor for the virus. And you can see, for example, when you do the experiment in virocell, you have good neutralization of the virus. However, when you use the Raji B cell, you have increased viral replication, so an indication of ADE. And they did the experiment in mice and in hamster cell. So again, here you see the luciferase activity, increased luciferase activity, meaning more entry of the virus. And you can see in virocell, you have as you have more concentration of the sera, you are neutralizing the virus. But as you have, on the other hand, you are having enhanced replication of the virus in Raji B cell that express Fc gamma receptor. So in summary, they showed that ADE, although they can see some ADE in vitro, but that did not translate into ADE in vivo. And the third study was published in PLOS Medicine in 2006. And here also they used a different platform. They used Venezuelan equine encephalitis replicon that express spike protein. So this is vector-based vaccine. And in this one, they used mice. And they, different to the other studies, they used homologous and heterologous challenge. So it seems that, and in this study, they used vaccine either against S or against the nucleocapsid protein or nucleoprotein. And their conclusion was that the S but not the N vaccine provide short and long protection against homologous challenge in young and senescent mice. The N-based vaccine not only failed to protect from homologous or heterologous challenge, but it resulted in enhanced immunopathology with eosinophilic infiltrates within the lungs of the challenged mice. So this is just like a comprehensive table showing the different groups that they included. I don't have time to explain all of it, but this is the experiment in young mice. These are the two groups vaccinated with either the spike protein or as a control with influenza HA, and you can see you have pretty much almost complete protection. So you have very low viral titer. And this against homologous challenge and against heterologous challenge also you can see whether you vaccinate with S or S plus N, you have pretty much low viral load. But if you vaccinate with the nucleocapsid, you do not protect the virus. Interestingly, you have these focal points in the lung indicating enhanced viral replication due to the vaccination with the nucleocapsid protein. The story was a little bit different in senescent mice. Vaccination with the nucleic acid by itself did provide protection, but not with S and N. And when you challenge with heterologous challenge, in this case, neither the N or neither S plus N provided the protection. So it seems the protection was better in the young mice rather than old mice. Again, you see these immune focal points in animals vaccinated with the nucleic acid by itself. Interestingly here, when you look at the antibody response in these vaccinated animals, in the young mice, you can see whether you vaccinate with S or S plus N, you induce good antibody response. In senescent mice or old mice, you induce good antibody response, lower than that of young, but still there's good antibody response if you vaccinate with the S. But vaccination with S and N in the senescent or the elderly mice, you do not produce good antibody response, which is a little bit surprising. And interestingly, the vaccination with HA from influenza induced good response in both young and senescent mice. So it seems there's something specific with the coronavirus spike protein and as well as the nucleic acid protein. And here, just looking at the immunopathology in the lung. So in the unvaccinated, but not in the S or even HA vaccinated, there was mixed inflammatory infiltrate with mixed infiltration of lymphocyte, eosinophils and basophils, as well as inflammation in the lung. The same thing was also observed. This was in the homologous challenge, and this is also in the heterologous challenge. There was inflammatory cell infiltrates, including eosinophils, in the unvaccinated, but not in the S-vaccinated animals. The last study I'm going to discuss today was published recently, last August, in Journal of Immunity. And the title was COVID-19 Vaccine Messenger RNA Elicit a Protective Immune Profile in Mice That's Not Associated with Vaccine-Enhanced Disease Illness. So in this case, they used messenger RNA expressing spike protein, specifically the Moderna virus vaccine, and they compared it to double inactivated vaccine and denatured spike vaccine. They used mice, they used homologous challenge, and the conclusion was the messenger RNA elicit neutralizing antibodies and spike binding antibodies, germinal cell B cells, so even like naive B cell can bind to these proteins. Humoral immunity is accompanied by both CD40H1 T follicular and CD8 response. So in this case, the response was not skewed toward type 2, but also the induced type 1 response, which is important for viral clearance. The vaccination demonstrated protection of mice from lung injury, and it did not result in enhanced disease illness. And this is they give two regimen 3 weeks apart, and they challenge at week 8. And you can see this is the group with the double inactivated virus, denatured spike protein, and messenger RNA. All of the vaccine induce binding IgG to the spike protein, with more antibodies in the messenger RNA, but only the messenger RNA provided good neutralizing titer. So the other vaccines, double inactivated or the denatured one, they produce binding antibodies, but they do not produce neutralizing antibodies. And the binding and neutralizing antibodies correlated well for the messenger RNA, but not for the double inactivated or the denatured vaccine. And when they looked at the isotypes, they noticed that the ratio of Ig2A over Ig1 in these mice was higher in the messenger RNA vaccinated, but not in the double inactivated or denatured spike protein. And we know that increased IgG1 responsiveness compared to Ig1 response confirmed type 2 response, which is a little bit harmful, as we see from the previous slides. and that was observed for the double inactivated and denatured spike protein. And this is just like another slide showing that in the messenger RNA, they have balanced response to TH2 or TH1. However, against the S1 peptide, S2 peptide, as always, but not to the N, because the vaccine does not have the N peptide. But when it comes to the double inactivated and denatured regimen, they induce more type 2 response compared to type 1 response. And here just showing that when we look at the virus titer in the nasal turbinates and the lungs, in nasal turbinates against the messenger RNA provided better protection. You have lower viral titer, and it was pretty much clear from the lung compared to double inactivated, and to less extent the denatured spike protein. Also, when you look at the lung pathology, when you vaccinate with messenger RNA, the lung is very clear. It resembles very much the naive mice that have not been infected. However, there are more lesions in the lungs that are vaccinated with the double inactivated or denatured spike protein, and that again, that's due to the inflammation and the infiltration of lymphocytes and other immune cells to the lung. There are several studies that describe enhanced disease illness. Most of them they used animal models, but the idea here is that sometimes the antibodies response to certain epitopes of the virus could be the reason for ADE. So antibody to one, like in this study, enhancement virus neutralization by SARS-CoV-2 antibodies from convalescent donor associated with distinct epitope on the RBD. And then in this case, they isolated antibodies from several antibodies from convalescent patients, and then they tested whether these antibodies enhance ADE. And they noticed, for example, some of the antibodies, they promote a neutralization. They are functional antibodies that can be used for treatment. However, antibodies to certain epitopes can mediate ADE in cells expressing the Fc gamma receptor. So in conclusion, ADE is a common feature with many viral infections, including respiratory viruses. ADE was demonstrated after coronavirus infection, including SARS-CoV-1, MERS, and SARS-CoV-2. Most of the animal that has been published was done in animal work and not much in a human. And also most of the work was done with homologous challenge, not heterologous challenge. And from my perspective, we really need to do more studies using heterologous challenge, because currently we have 6 coronaviruses in nature. We have SARS-CoV-2, we have MERS still in camels that might emerge, and we have other 4 seasonal coronaviruses. So challenge vaccination, the mixed or heterologous vaccination challenge is very important in this regard. According to some studies, ADE is more likely to develop in patients or persons vaccinated with inactivated virus, whereas the native whereas vaccination with the native spike protein does not induce ADE as much. And further studies are needed to study the correlation of previous coronavirus infections, different IgG types, demographics, like to induce ADE. This is it for me, and thank you much.
Thank you, Dr. Hadi. And I believe we have a better understanding for the ADE effect after hearing your incredible sharing. So indeed that in other infections, like in MERS, SARS, RSV, already have seen the ADE effect. So it is worth discussing for the ADE effect in COVID-19, since the vaccination area is coming. Thank you again, Dr. Hadi.
Thank you, Leah. I have only maybe like 7 minutes because I have another presentation to attend. So I can take a few answers now.
Okay. So despite our running out of time, my colleague has already helped me select some questions. So I have one question for you, Dr. Hadi. Maybe after this, you can go for another meeting.
Yes.
So the question is from our audience, and he or she asked, how common is ADE, and any specific group of people that may have higher chance of experiencing ADE?
It depends, like, on the virus we are talking about. As we discussed, like, ADE is found with different viruses, so it is a common, and it might be common with more viruses like dengue virus and these arboviruses compared to respiratory infection, but still in respiratory infection. Work is still ongoing regarding coronavirus infections, but there is indication that there is ADE to a certain part, and it's mostly associated with vaccination with inactivated virus.
Okay. Thank you so much, and I hope this can have a better understanding of this question from this audience. And thank you so much for the explanation. And we have 2 or 3 more questions for Dr. Gheyath. And the first question is, the antibody will decline along with the time after vaccination. So Dr. Gheyath, would you recommend us to test for antibody after the vaccination? And what is your suggestion?
Thank you very much for this question. I am not a clinician, and this question has been raised a lot. And in Qatar, even people still, they are positive for neutralizing antibody, but the government, according, maybe to the WHO or from recommendation of Europe, to take the 3rd dose. And eventually people are taking the 3rd dose, even though they are still positive. They did not recommend people to go and test for their antibody. They just, they said after 8 months or 8 months, and in some countries, 1 year, you need to take another dose. So my answer to this question, I cannot answer this question perfectly. For myself personally, I would not go for the 3rd dose as far as I am still positive for the antibody.
Okay.
Maybe Hadi has another opinion he can share before he go as well.
Yeah, maybe Dr.
No, I don't have anything to add.
Yeah. Okay.
Okay, Dr. Hadi, if you have a rush for another meeting, you can leave the Zoom room now.
I have a couple of minutes, so I can take 1 or 2 questions if you want.
Okay, that's great. And another question is from another professor. It's a professor in India, Professor Ashok. He asked, did you, for Dr. Gheyath, did you have a person in your study that did not respond after vaccination? And what's your suggestion for people who do not have any response for the vaccine?
That's very excellent question, and we tested more than 450 samples. Unfortunately, there is only 1 person that did not produce neutralizing antibody by the viral neutralizing assay, but the rest, they are all respondent and they produce high level of antibodies. And interestingly, this case was not only negative by viral neutralizing assay, even we test them with the Wondfo, with the rapid test, and she showed negative result as well, demonstrating the specificity of the assay. So no, I will say 99.9% of people taking the mRNA vaccine, they produce high level of titer at the beginning, as I showed you.
Yeah, thank you. So in your research, you showed to us that You mean only one samples in your study is just negative for the all the
No,
assays?
only negative for neutralizing antibody, but she is positive for others.
Okay, only negative
Yeah.
for neutralizing antibody.
Yes, exactly.
So your suggestion is just to scale up.
For that one, she has to go the third dose for sure. Yeah.
Oh, right. Because in your study, you suggest a value, it's 109 BAU. So for people under 109 BAU per milliliters, what's your suggestion? Is it should?
Yeah, that is the this one came very lately. I mean, from a study group in Italy that I am collaborating with them,
Okay.
and according to the assay that we are using, the Mindray assay, if the neutralizing antibody is less than 100, mean the protection will not be excellent. You will have you have a protection, but it's not an excellent according to the WHO. However, by the neutralizing assay, if you have an inhibition more than 30% now, it used to be 20%. Now, I think by the WHO, they raised it up to 30%. Then your protection is very, very high.
Okay, okay. Well noted. And there's another question for Dr. Hadi. Can we detect the specific antibody that can potentially cause ADE and then try to avoid it? So he wants to ask, the antibody test will help in ADE?
So I read this question and I was gonna answer it even before you asked. So this is a very interesting question. So like in my last slides, I showed that in one group, what they did, they isolated antibodies against different epitopes of the spike protein, and they can say that epitopes or antibodies to certain epitopes might be associated with ADE compared to other antibodies. And yes, with some work, you can identify certain epitopes that are targeted by antibodies that might induce an ADE, and then you can design your immunogen, your spike protein, in a way to prevent the induction or elicitation of these antibodies. And this is why the direction of the vaccine development now is going towards structural base of vaccine development. So they are trying to use the structure of the protein, understand the immune response to these proteins, and then try to elicit neutralizing and prohibit the elicitation of non-neutralizing antibodies. They are doing this for corona. They have been trying to do this for HIV, and I think they are also testing similar strategies for RSV as well.
Okay, okay, thank you for your explanation. So there's one question. Okay, it's for Dr. Gheyath. You share a lot of methods for antibody tests like chemiluminescence, LFA, and SVNT. Very useful information. So which methods would you recommend to use for which scenarios? It means in different scenarios, will you have a preference for different methods?
That's a very tough. This is a very tough question, actually. I think all assays are good. I mean, even people at the beginning, before the vaccine production, we were studied assays that are specifically to the N protein. So when we did correlation with the RBD, then you can have some prediction if you produce antibody to N, and then for sure you will produce antibody to the RBD. So in this case, I guess all assays are good, but as a reference assay, I think we should go back always to neutralizing assay regardless of the manufacturer. Yani whatever the manufacturer is. So I think the reference is always the neutralizing assay, and all of the other assays have very good correlation, although it's not 100%, but it will give you very good idea about the neutralizing antibodies. If you are positive by any of the assays that I show you, I mean, there is a percentage of true results more than 70% by any of the assays.
Okay. I think you have made a very good explanation, because different assays, and because the gold standard now is for neutralizing antibody is neutralizing assay, and other methods that have a good correlation will have a potential prediction for the neutralizing antibody.
Exactly, as I showed you, as I showed in my presentation. Yes.
Thank you so much. So I think our webinar has to come to the end, and thank you so much, Dr. Gheyath and Dr. Hadi, to join our meeting today. Thank you.